First of all, I am Cindy Stevens, and I work in nursing outreach with Shirley Farah, and you've met Todd and the people who were signing you in as you came in. I always tell people we are a small group but mighty. So, Dr. Alex Bryant serves as the Infectious Diseases Clinical Specialist and co-chair of the Antimicrobial Stewardship Committee at Mercy Hospital in St. Louis. He is also an adjunct faculty at the St. Louis College of Pharmacy. Dr. Bryant received a Doctor of Pharmacy degree at St. Louis College of Pharmacy and completed a residency in pharmacy practice at Louisiana State University Medical Center in Shreveport. He completed a residency in infectious diseases at West Virginia University Hospital, Morgantown. Dr. Bryant has several published articles, most recently looking at C. difficile infections. He has presented numerous posters at national conferences and meetings. Please help me welcome Dr. Bryant as he speaks on antimicrobial stewardship programs, Missouri exemplars, how to create, implement, and sustain ASPs with a focus on a larger health system.
Thank you very much, and I appreciate the opportunity to come and speak to you all. I realized during the keynote address that many of my slides and a lot of what I'm going to be talking about is going to be similar just because of the fact that what he was describing is essentially how we should model ourselves in starting and implementing a stewardship program. So what I'm going to try to do is give a little bit more experiential kind of opportunities for folks who already have stewardship programs and are trying to bolster those, or if you're trying to get a stewardship program off the ground, and give some examples of what we're doing in our hospital as well as the system of hospitals. And it's interesting that we say that this is a large hospital system, and where I'm at is a very large hospital, but it is interesting because I get to interact with a lot of critical access hospitals in rural areas. And recently I was asked to co-chair our system Antimicrobial Stewardship Committee. And so I'll give you some examples of what that looks like and kind of what the Mercy Health system looks like as well. So the objectives for today will be for me to provide some reasons why antimicrobial stewardship programs are essential. Identify the core elements of antimicrobial stewardship programs, which we heard kind of a precursor to that this morning, and we'll go into a little bit more detail about that and how we can apply those. Recognizing the importance of collaboration with the microbiology department and infection prevention. I think that this is a very integral piece to antimicrobial stewardship, as many of you are aware of. And discussing some ongoing and future stewardship efforts that we have at our hospital in St. Louis, as well as our system of hospitals. I like to start stewardship talks, any stewardship talk, with this quote. Many of you are probably familiar with this, but especially for folks who are not in the stewardship arena or are not familiar with this, I like to provide this to residents and fellows when I speak to them about educating from a stewardship perspective. And this is a quote from Alexander Fleming in 1945, so shortly after the introduction of penicillin to the masses. And he says, "The public will demand the drug, and then will begin an era of abuses. The microbes can be educated to resist penicillin, and a host of penicillin-fast organisms is bred out, which can be passed to other individuals and perhaps from there to others until they reach someone who gets a septicemia or pneumonia, which penicillin cannot save. In such a case, the thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to this infection with the penicillin-resistant organism, and I hope this evil can be averted." And so I think that this is really poignant. And it also highlights that resistance is not a new concept. This is not something that is just recently been discovered. This is something that we've known about basically since we discovered that antibiotics existed. And so I think it's important when you're talking to providers or when you're talking to your peers to make sure that folks understand that it's a difference when you're prescribing an antibiotic. This is different than if you prescribe a blood pressure medication or a statin or something like that. Those medications have significant consequences to the individual that it's being prescribed to, whereas antimicrobials have consequences to every person who comes into contact with that person, essentially. And so in the hospital setting, obviously we see that in a very concentrated sense in units with very susceptible hosts. And so this, kind of ties everything together from an infection prevention and stewardship aspect. But keep that in mind when you're educating folks and just as we're talking about these topics. So just to kind of further define what is antimicrobial stewardship, I think that this is also important. This is from the most recent guidelines that just came out in 2016. And so the definition that they decided on was a coordinated interventions designed to improve and measure the appropriate use of antibiotic agents by promoting the selection of optimal antibiotic drug regimen, including dosing, duration of therapy, and route of administration. And so for me, when I hear this, obviously there's a large component of pharmacy in this. And so, one of the things that I've done is to try to, in our larger hospital system, is to educate our pharmacists who are maybe not as familiar with the clinical aspects and not as involved in interacting with physicians. Especially when I first started at our hospital, that was the situation. And so since then, we've implemented a lot of things that we'll talk about. One of those things is an automatic renal dosing program. And so instead of calling the physician, we basically put together a lot of protocols for the antibiotics that we use routinely. And we said, why don't we just adjust these automatically? And so if there's a question, obviously we're gonna have that conversation with the physician, but to save everyone's time and be as streamlined as possible, we just do that automatically. And so that's just one example, and we'll talk about a few more of those examples as we go forward. And then the other question is, what is the benefits of antimicrobial stewardship? And so we heard some of those benefits this morning, but the definition from the guidelines basically say that it's to improve patient outcomes, reduce adverse effects, and they specifically highlight Clostridium difficile, which is something obviously that's a very important piece of antimicrobial stewardship, improvement in rates of antibiotic susceptibilities to targeted antibiotics, and optimization of resource utilization across the continuum of care. So I think that to most of the folks in the audience here, this is an obvious statement. And so the question is, especially if we're talking about implementing a stewardship program, is how do we convince other folks in our institutions to buy into this? And so from my own perspective, I was lucky enough to come into a hospital that had at least the start of a stewardship program. And what I noticed is that it wasn't a really formal process. It was a very kind of abstract process. So the thought was out. There were activities going on, but it wasn't a very formalized process because there was not a dedicated, responsible person for that per se, and there wasn't a clinical pharmacist in that role to kind of help support and educate and further that. And so that's kind of the task that I took on whenever I started my job at Mercy Hospital about 6 years ago. So how do we help providers and the C-suite or the administration understand the big picture? And I think one of the things that we need to highlight is that stewardship is not the antibiotic police. We're not trying to just restrict antibiotics from a cost-saving measure. We're not trying to just, control the use of antimicrobials arbitrarily or in a kind of a punitive way. And I think that at least whenever I started at Mercy, there was a little bit of that going on. There was a thought that, from an infectious disease physician standpoint, that they were trying to get more consults by restricting antibiotics. And that's just a misconception. And so one of the things I had to do is break down that barrier. Especially with our critical care physicians. There was a little bit of animosity. Don't tell me how to use these antibiotics. I know how to use antibiotics. And so breaking down those barriers and making it a much more collaborative process was really helpful for us. And now I'll give you some examples of how we work with our critical care physicians to really empower our stewardship program, because we know that in that population, they're going to need to use a lot of broad spectrum antibiotics. And so we altered our policy a little bit. We made it more inclusive, and we also asked some of them to start sitting in on our stewardship committee locally and get some of their feedback as we're doing this. And you'll see that this is a common theme that I'm going to be talking about, is really communication across multiple levels. The public reporting in the future, so we heard this morning, this is not going to be something that's going to be immediate, but I think in the future there will be some component of public reporting. And if nothing else, we know that the C. diff rates are going to be publicly reported, or are publicly reported right now. And we heard a lot about that this morning. And I think antimicrobial stewardship is obviously going to play a huge role, or is playing a huge role in those C. diff rates. And so this is something that I know from our hospital standpoint, now that we are reporting C. diff rates, there's a huge momentum shift from the support and financial incentive, essentially, from our administration and from our system. And so all of a sudden I see a lot of the things that I've been thinking about, many of you have been thinking about for the last few years or beyond, are now gaining some momentum because of these public reporting and because of these measures. And so I think that it's a very important time. We need to grasp this opportunity and really take advantage of that. So if you're in a hospital and you have that, make these examples and show this and partner with your infection preventionists, because they've already been seeing this stuff from a public reporting standpoint of surgical site infections, CAUTIs, CLABSIs, and the like. Tying it to reimbursement and accreditation, again, we heard a little bit about this, the value-based purchasing module. This is going to be a function of participation for Medicare and Medicaid. We heard about the opportunities that we have from the Leapfrog survey, and this is something that just this year I've been asked from a lot of the quality folks in our hospital to address these questions. And so again, this is just another opportunity. I think this is a perfect time in our society and in the culture that we're in right now to basically ride this wave of momentum that's coming from the top down. The cost savings as a result of quality, I think this is another misconception that, especially in the pharmacy perspective, that we have to address, because oftentimes, at least in my experience, the administration likes to look at each individual department as kind of an individual silo. And so the pharmacy oftentimes become a cost center. And so how do we make the case that the value and the cost savings really comes on the back end? So these are kind of what people would think of as soft dollars. I've always had a hard time, how do we quantify things that are not happening? So I'm trying to prevent things from happening. How do we quantify that? And so I think some of the ways that we can do that are some of the reporting modules that we have. We can also look at C. diff rates, and we can look at antibiograms and other things that we can look at to report to the C-suite and say, here's the impact that we're making. Here's our partnership with the microbiology lab, our partnership with the infection prevention, and kind of making that case in that sense. The executive order, we'll talk a little bit about that Arjun mentioned this morning, and the Missouri state law also he mentioned, but here in Missouri we also have the benefit of now that it's a state law. So even if you go through all these things and your administration doesn't want to start a stewardship program, they basically have to start a stewardship program. So that's kind of a good compelling reason to start a stewardship program, is that we now have a law. So I think, again, in Missouri, we're lucky that we have that, because it just helps kind of further garner support for that in our institutions. And then we have to think about antimicrobials as a shared resource. I have a quote at the end that I think really drives this home, and it goes back to what we said. I mean, we have to look at antibiotics differently than we look at other medications, and kind of make that case to the folks who don't really understand that. So to briefly go through the executive order of the president, this is some of the goals that he set out in his speech and the executive order. So by 2020, the goal is to establish a stewardship program in all acute care hospitals and improve stewardship across all healthcare settings. And so the key to this, I think, is across all healthcare settings. And so while I'm not going to focus a lot of my time on the long-term care side and the ambulatory care side, I think that part of what I struggle with is that if you look at some of the statistics, we look at how antimicrobials are used across the continuum of care. And so 80% of antimicrobials used in our country are actually used for growth promotion in agriculture and animals, essentially. And so that's a huge component. And so that leaves us at roughly 20%. And so of that 20%, only about 3 or 4% from the statistics I've seen is actually used on the inpatient side. And so we're focusing a lot of resources, a lot of attention to the inpatient side, but there's still a huge component in the community. And so I think it's important for us, especially when I think about the Mercy system, we have a huge Mercy clinic, we have a lot of primary care doctors, and so how can we influence that, the prescribing in the community? And ultimately, when we share these patients with long-term care, skilled nursing facilities, and nursing homes, we know that these places are having a lot of C. diff, a lot of resistance because of the patient populations and because of the necessity to use antimicrobials. We need to reach out and partner with those folks, and we'll talk a little bit more about some of those things that we're doing. Reduction of inappropriate antibiotic use by 50% in the outpatient setting, as I mentioned, and by 20% in inpatient. Establishing antibiotic resistance monitoring across the 50 states to try to figure out how we can more quickly identify potentially MDR outbreaks. How do we communicate better when we're transferring patients from one place to another to make sure that the system that's receiving that patient has the same information that we have, and vice versa. And then elimination of the medically important antibiotics for growth promotion in food-producing animals, which I think is a huge aspect. This is something that, obviously I'm not going to spend a lot of time on, but it is something that if you're not familiar with, I would encourage you to kind of look into that and see what opportunities are available to start trying to change that. And hopefully this will be something that we can address from a community standpoint as well. Just to briefly mention this, Arjun touched on this, but in Missouri we have the Senate Bill 579, and so this is essentially the law that was passed that he was mentioning, and I guess I didn't realize just quite how progressive it was, but from what he's saying, I feel like that this is a very fortunate situation for us in Missouri, especially considering the situation that we're in. So basically, again, to say that he mentioned this, but no later than August of 2017, each hospital and ambulatory surgical center, which may be complicating for some of these ambulatory surgical centers, that's an interesting piece of how we're going to operationalize that, the stewardship, and how does that look in those centers. We'll have to establish a stewardship program. And hospitals will have to meet specified national standards for reporting and antimicrobial usage. And so, again, this is going to garner more support for the NHSN and the AUR piece that we heard about this morning. I know for our hospital right now, that's something that we're working on, is how do we report this information in NHSN? How do we work with our vendor to get this information there? This is kind of new for me, at least from a stewardship standpoint. So it's another example of how I personally want to team up with our infection preventionists, because they have the experience in this aspect. So to kind of further make the case, we can look at it from an economic and clinical perspective. This is some just statistics from the CDC. Most of you are familiar with this, but conservatively, the estimates are that 2 million people are affected every year with an antimicrobial resistant infection. So when you start throwing out these large numbers, I think it's hard to put it in perspective, but we can all think about individual cases that we see on a regular basis. But this is a huge problem. I think it's important to use these statistics as well to make a case to the public and try to get partnership in the public. We'll talk a little bit about that when we talk about education, to try to get basically more support from the people who are coming into the hospital who may be demanding antibiotics in the clinic, and try to help them understand this effect. 23,000 people dying as a direct result, with many more succumbing to conditions like C. diff. Total economic cost. So when we talk about those soft dollars, we can throw out some of these numbers. I have an example here that we'll look at an individual hospital and some of the quantification they did for the cost of these antibiotic-resistant infections. But $20 billion in excess to healthcare costs, with additional societal cost of lost productivity of $35 billion, and this was in 2008 dollars. And then just the obvious statistic that we keep hearing about, that up to 50% of antibiotics prescribed are either ineffective as they're ordered, or they're not necessary. And so I think this just gives us even more support to go talk to providers and say we have a lot of room for improvement in this aspect. This kind of gets it more on like an individual hospital level, a little bit more granular. This is a study in 2008 that looked at a Chicago teaching hospital. And they basically found around 1,400 patients that they looked at. 188 of those, roughly 14%, had an antimicrobial resistant infection. The cost attributed in this cohort was $18,000 to $29,000 per patient. And so I think these are numbers that are going to grab the attention of your C-suite whenever you're mentioning these information to them. The additional days in the hospital, which we know length of stay is a big component of our reimbursement when we're thinking about these quality measures. Additional length of stay was 6.4 to 12.7 days, and there's an attributable mortality of 6.5%. The societal costs that they estimated were $10 to $15 million just in this cohort. And using the lowest estimates from the sensitivity, a total cost of $13.35 million, and this is in 2008 dollars. So again, we can throw out those big numbers from the CDC, but bringing it down to a kind of a level like this, I think helps put it in perspective for an individual institution. And so to kind of move into that, for those of you who are not familiar with the Mercy Health System, this is just some information about what the Mercy Health System is. The hospital I'm at is in St. Louis, but you can see all these little dots essentially represent everything from our hospital being the largest hospital in the system, roughly a 900-bed hospital. Our partners in Springfield have a roughly 800-bed hospital, and so there are some large institutions within our system. Our Oklahoma hospital, I think, has about 500 to 600 beds. And then we also have everything down to critical access hospitals, and we also have partnerships with hospitals that are not part of our system, but we offer services even to some small critical access hospitals in our area. So there's 11 specialty hospitals, covers 4 states, which is also interesting to kind of navigate the different laws and the different regulations in different states as we work together and try to streamline our efforts. The 2015 inpatient discharges was 151,241. You can see the data for our surgeries and ER. And then the outpatient visits, I think, is something that I was not familiar with because I don't interact as much on the outpatient side. But there were 2,996,395 outpatient visits. So, when we talk about the antibiotic use in the outpatient setting, I think this just highlights how potentially excessive it is and how much opportunity we have in that realm. So as Arjun mentioned this morning, I just kind of wanted to go through this and give some specific examples of how when you're looking to implement a stewardship program, how to sustain it. I think that this playbook, the NQF Playbook, is really an excellent place to start. They really do a great job of summarizing and giving examples. And this is based off of the CDC core measures and the core elements of stewardship. So basically what this does, and what Arjun obviously mentioned this morning, is it provides examples, it gives rationale and overview, and I think the best part that it really offers is it gives potential solutions to barriers. And so I think this personally for me is something that recently I was asked to co-chair the system stewardship meeting, or stewardship committee. And so basically, I'm in St. Louis, and I really don't have a good feel for what's going on in all of our smaller hospitals and even some of our larger hospitals. I interact with a lot of the pharmacists there that are doing stewardship, but each individual institution is going to have a different need. They have a different administration. They have a different patient population. They have a different antibiogram. And so in one way, it's very overwhelming to think about that because I'm thinking, how am I going to affect all of these individual patients? But in reality, I think there are some opportunities. I'm going to highlight some of those things as we go through this playbook and try to give you some specific examples of just, I don't want to say low-hanging fruit, but some very obvious opportunities that we can kind of address as we're going through this. So leadership commitment, we talked about making the case. So once you've made the case and you get that support, what does that look like? I think a written support from your administration is one of the key things, as we found before. Dedicating necessary human, financial, and information technology resources. Accountability is a big one that we're going to talk about next. And I think one of the interesting things that was brought up was telemedicine. And so how do we use telemedicine to reach these critical access hospitals? Mercy is a very virtual, very wired institution, if you will. They just built a virtual care center outside of St. Louis. And Mercy offers what they call EICU services to a lot of hospitals within our system as well as outside of our system. And so we have the infrastructure to do that, and right now as a system we're trying to figure out how do we leverage that technology, how do we leverage that platform to meet some of the needs for antimicrobial stewardship. I think one of the potential limitations of that is that I feel like one of the benefits from a stewardship standpoint that I have is the connection that I make with the providers, the residents, the fellows that I deal with on a regular basis. Being in front of them and having face-to-face communication I think is more effective than just sitting at my desk and calling them and kind of being this unknown face. So giving talks at grand rounds, doing those things. So that's one of the potential limitations I see with telemedicine, because I think if you talk to folks in the Mercy system, they think the hand of God is coming down. The EICU can camera into their patient rooms and start having these conversations with physicians. So how do you take it away from that perspective and say it's much more of a one-on-one conversation and more inclusive? So I think that's something that we have to address, and that starts at the top from a leadership standpoint. With accountability, I think this, again, is going to be a key. So if we have a leader, we have to be held accountable for those things. And so that goes back to what are the benchmarking pieces that we're going to address. And I think that even we heard this morning on a national level, this has really not been completely vetted out. So one of the things that we look at is the days of therapy per 1,000 patient days. And we'll talk a little bit more about that from a tracking and reporting standpoint. But I think that that's at least a place to start. And so once you have that established, there has to be accountability, or this is just basically not going to work. The drug expertise, this is something that I obviously hold near and dear because of what my role is in the stewardship program. But having a trained clinical pharmacist is ideal. The reality of that, though, is that there's not enough infectious disease pharmacy residencies to meet the need for stewardship. So we think about the number of hospitals in the country, or even just in Missouri. We say that now there's a state law for creating a stewardship program. We say that there has to be drug expertise, but in reality, there may be 100 or 150 clinical pharmacists each year completing residencies, and that's for the whole country. So how do we meet that need? How do we fix that problem? One of the things that one of the organizations that I'm very that I interact with a lot and I participate in is the Society of Infectious Disease Pharmacists. And what they did was they actually started a certificate program. And so what this certificate program does is it gives some didactic training in antimicrobial stewardship and basic infectious disease training. And then they actually take it a step further and say that the individual has to implement an intervention or a program in their hospital. And so they have the SIDP members that can help kind of foster this and help guide them. But then once that's completed, then they get kind of an assessment from a board and they can get this certificate. And so it really is trying to fill that gap. If you have pharmacists at your smaller institutions that are already serving in stewardship roles but need a little bit more expertise, a little bit more support from that standpoint, this is an opportunity. MAD-ID is another organization that also has a stewardship program and trying to fill this need essentially. And so I think it's important though to kind of hold the drug expertise to this standard and not to just expect just any pharmacist to kind of fill this role. Or if you don't have pharmacists, I know some of the critical access hospitals in our organization don't even have 24-hour pharmacists. So that's how small some of these places are. You know, they may not have a pharmacist on staff all the time. They may come, you know, intermittently. So if that falls to an infection prevention nurse or if that pharmacist is expected that, we need to be able to support those. So is that telemedicine? Is that a stewardship program like this? Those are questions that we have to figure out. And then ensure the pharmacy leader trains and works with other pharmacy staff. This is something that I've spent a lot of time doing because I'm one individual person for a 900-bed hospital. And so I have one other clinical pharmacist that works in our hospital that's employed by the hospital. He's a critical care pharmacist, and he and I collaborate a lot. And so between the two of us, we try to cover as much as we can, but in reality, we need to basically use other tools, whether that's technology or decentralized pharmacists or other folks in the area to really help us make our program successful. And so without the education that we provide to those folks and without their participation in the program, it really wouldn't be as successful as it is. So I think that's another important piece, is to make it as inclusive, make everybody be on board with this process as you can. And so this is one of my favorite things to talk about. This is where we'll get into some of the examples of things that we've implemented in our system, and I think it's things that could probably be applied to really any system. And I'd say most of the folks here probably have examples of this too in one form or another. And I think it's also important to remember that not one size fits all. If there's anything that I've learned just from working with the hospitals in our system, is that each hospital has its own specific need. And so there are principles that we can apply, but how those principles are applied really need to be tailored to that individual institution. So assuring timely and appropriate cultures. This is a very basic function, but it's something that you need to ensure is happening, because how can we de-escalate, how can we target a specific organism if we don't know what that is? And I think that a lot of times is one of the big barriers to de-escalation, is if we don't have good cultures or we don't have culture data, how do you choose which antibiotic to drop? And this is a question I get a lot of times from our critical care physicians. Can you put a protocol together that tells us this? There's really not one protocol that we can follow, but we can educate and kind of highlight the principles of how we make those choices. So something to make sure that we're doing from an action standpoint. Requiring documentation of the indication, the drug dose and duration, implementing prospective audit with feedback strategies, which is a basic function of our stewardship programs that we should be doing. How that looks in our hospital, we have kind of a targeted antibiotic list that I'm looking at on a regular basis. And then I also use our decentralized pharmacists a lot to help filter information to me. So as they're verifying orders and they see things, they may say, this order doesn't look quite right, or I don't understand this combination of antibiotics. So the idea is basically that they realize that there's something that's not quite right, and then they can filter that to me, and then I can spend my time looking at that or addressing that with the physician. Developing facility-specific treatment recommendations based on national guidelines and local susceptibility data. This is something that we've done. We have the EPIC system, which I'm sure many of you are familiar with. And what we do is we have shared order sets and pathways throughout our system. And so we use national guidelines, obviously, to choose the antibiotics that we put on there. I think one of the most helpful things that we've done, though, is to put some wording around when to choose certain antibiotics. And so I'll give some examples of that whenever we see some of the actionable things that we've done. Establishing a process to review antibiotics prescribed after 48 to 72 hours, an antibiotic timeout. And this is something that I've really wanted to do for a long time, and it's been difficult because Epic is a resource that we have to share with a lot of other folks around the system. And so just like everyone else, the folks that work on Epic for us have a limitation in the time, and they have their own priority list. And this is going to be something that I would consider kind of a big build. You know, this is something that's going to take some thought process, some time, and a lot of effort. And so right now, I'm trying to gain the momentum that we have with the C. diff data that's coming out, and at least on our own institution, the desire to lower our C. diff numbers. And this is one of the things that we're going to implement. I'll show you kind of a mock-up of where we're at. We don't have this fully implemented yet, but it's something that we're really working on and we have good support for. So it's in its infancy, but I can at least give you an example of what that's going to look like. And then establish guidance on dose adjustment for the cases of organ dysfunction. This is something I mentioned earlier about our automatic renal dosing program. And I think that that's something that it seems pretty obvious, but when you talk to a lot of other pharmacies around the area, not a lot of folks are doing like an automatic renal dosing based on a protocol. A lot of times that's still a conversation with the physician. So I think that that's a helpful piece of that too. We know that optimizing the antimicrobial dose could potentially help better outcomes. It could also help decrease the rate of resistance development. So I think that this is going to be important as well. So this is a screenshot from our Epic system of what our antibiotic indication looks like. So basically you have some buttons here that are basically asking the provider, what is the indication for this antibiotic? So theoretically, this should help stimulate that thought process. Why am I using this antibiotic? You know, you kind of take out that thought process of, oh, I'm just going to order vancomycin and levaquin, or I'm just going to order, you know, some kind of standard coverage in that setting. And the reality of it is that we hope that people are stopping to think, is this an appropriate antibiotic combination for what I'm doing? On the backside, it helps the nurse know exactly what the indication for the antibiotic is, which I think is helpful from an education standpoint, from a communication standpoint. And from the pharmacy standpoint, it's very helpful because this gives us a lot of information. We can tell, one, whether or not the antibiotic's appropriate. We know that the physician note is not going to be there necessarily at the time with the full thought process, but this gives us an idea if we're going to dose antibiotics, we obviously need to know what the indication is because that's going to alter potentially what the optimal dose should be and those type of things. So this was actually, I think the limitation here would be alert fatigue. When you have an automated system like this, there's always a question of if we just keep sending alerts to the providers, what's the value of that? Are we just gonna get burned out at some point? And so part of that was for us to go and really get a good conversation, to reach out to the different groups. And when you're talking about implementing this for 34 plus hospitals, all the different information that's out there, one of the ways that we address that is by specialty councils. And so we have a critical care specialty council for the system, we have an infectious disease specialty council. And so there's representatives from each kind of discipline within the system, and this information filters through those, we get feedback. And so that way when we put it into a live context, into the live system, people aren't shocked by this. And so yeah, we did get a little bit of feedback. Why do I have to click this button every time? And so one of the things we did to try to decrease that was to default the order sets. So if you're choosing the pneumonia order set, it would choose pneumonia as your indication. That way you're not constantly having to click those buttons. It also helped us with surgical prophylaxis. You know, we want to make sure we're stopping that surgical prophylaxis after the surgery. So if we're using cefazolin, we make sure to stop that dose. Sometimes it wasn't always clear in the surgeon's note, what's the indication for this? Do you want it to keep going? Was there some kind of, say, bowel perforation during the surgery, or do you want this to stop? Now we know, you know, this is just for surgical prophylaxis, so if there's not a stop date or they choose it incorrectly, we can stop that promptly. These are just some of the examples that we have. This is actually something that goes into every patient's chart note for a critical care patient. So anyone in our ICUs gets this added to their chart. And so I think that oftentimes checklists are probably a good way to make sure that something's happening consistently, because as humans, we are gonna forget to do things unless it's something that's just repeated over and over again. And so at the bottom here, you can see we partnered with our critical care physicians, and they agreed to put this in as part of their daily checklist. And so antibiotic de-escalation. So on a daily basis, when they're discussing those patients on rounds, they're discussing the opportunity for antibiotic de-escalation. And this seems like a fairly simple thing to do, but it is something that we had to kind of convince them to do because there's obviously a limitation of what they can put on the checklist. So I was very happy whenever they agreed to do this, and I think it's made a big difference. I see a lot more thought process being put into the choice and the potential for de-escalation. But just having this is not enough, I can tell you that. We get new fellows every year, and so we have to go back and kind of re-educate the fellows that are coming in and say, this is why this is so important. So that's that piece of trying to sustain your stewardship program. You can't just do this one thing and then say, put it on autopilot. You have to kind of go back and reinforce why it's important. So this is the example of the mock-up of what I was talking about, the antibiotic timeout. And I'm sure if anybody has an example of this, I would like to see it as well, because I think that, at least from what our Epic folks said, there's not a lot of models out there that they could find within kind of the Epic world for something that's automated. So I think a lot of times we could educate folks to say at 48 to 72 hours, we need to take a step back and reassess these antibiotics. But if we can automate this and have this happen every single time, obviously it's going to be more consistent, it's going to be more effective. And so what this says, if in case you can't see it very well, I apologize, that's kind of small wording. It says, does this patient have an infection that will respond to antibiotics? So that's probably a good answer. You should answer that question on day 2 or 3 if the patient's still on antibiotics. If so, is the patient on the right antibiotic dose and route of administration? Can a more targeted antibiotic be used to treat the infection? And how long should the patient receive the antibiotic? So it's asking these questions, and the CDC recommends for this to be at 48 hours. Within our own system, I think right now we're thinking about 72 hours because a lot of our microbiology data is going to be coming back at 72 hours. That's something that I think needs to be talked about at each individual institution. When do the physicians round? What kind of information are they looking for? And a lot of what I'm looking for is just feedback from different providers to see when that's optimal. And so if you want, after this, we can talk a little bit more about how we're going to try to operationalize this. But I think that this is something that is going to be very helpful for us in our efforts. And it's another example of how, as a large healthcare system, we can use this computerized technology to help our hospitals that don't have a clinical pharmacist, who don't have an ID physician. This is going to at least help get the ball rolling. So this is helping that conversation being started, and it gives them something to work off of on their day-to-day practice. When we look at tracking, this is another thing that I think has been kind of a question for antimicrobial stewardship. What is the best data for us to collect? What's the most meaningful data to collect? And so one of the things that we look at is adherence to facility-specific guidelines. So how often are people using the pathways or the order sets? If they're going off of the pathways and order sets, are those appropriate? And so there's a lot of information you can get from that, because if we see a specific order set that's not being used, we can go back and say, is this really an optimal choice of antimicrobials on our order set? Do we need to adjust that? We can get feedback from our providers. Time to initiation or de-escalation. This is something that at this point, what we've done from a septic shock standpoint, we definitely look at the time to initiation. That's something that we've looked at a lot and partnered with our critical care physicians on. And they've presented a lot of data and posters in regard to that, some of the programs that we have that I won't really get into. But the de-escalation piece is one that makes it a little bit harder. This is something that you might have to manually extract from the chart. And so the way I address this at our hospital is I use our pharmacy residents to do drug use evaluation. So we might look at 3 months of data from 1 year, 3 months of data from another year in a similar population, and say how fast are we de-escalating? Are we de-escalating appropriately? And then we can present that information to our stewardship committee, to our P&T committee, and then I try to go out to all the different physician groups that this information is going to affect and kind of give them that feedback. We'll talk a little bit about that in reporting. Antibiotic use and resistance. Obviously, antibiotic use, we're going to look at the days of therapy, as I mentioned next, days of therapy per 1,000 patient days. And from a resistance standpoint, we're going to look at our antibiogram. And so this helps kind of trend resistance over time. It also helps us with our choices of empiric antimicrobials that we're going to put on these pathways and order sets. And so this is obviously an integral piece. In the future, we know that this factor, this antimicrobial resistance piece, is going to probably be reported as well. So when we start reporting this to NHSN, we can kind of pair this up with our antimicrobial use. But depending on what your ability to collect this data is, there is some opportunity to start doing this right now in your hospitals, even without NHSN. And then when you get to NHSN, hopefully it'll just be easier to kind of graphically represent that. The standardized antibiotic administration ratio, I won't go into this in detail. Obviously, Arjun mentioned that this morning, and so I'll just leave that at that. And the drug use evaluation, as I mentioned, I think that's a very key thing that we can do to try to get a more granular look at this antibiotic use. It's one thing to look at this big aggregate data, but then when we look at it on an individual level or a smaller level, it helps contextualize what's going on in your individual institution. Reporting, I think that this goes back to what I was mentioning about communication. Trying to make everyone in your institution aware, understand what kind of stewardship efforts are out there. A lot of times I've heard of studies where they looked at it, or reports where there's a very robust stewardship program, and then they went and asked a lot of people in the hospital, and the folks didn't even know like what's stewardship. You know, they didn't have any idea. So the people who were doing stewardship thought, hey, we're doing a great job, we're doing all these things, but the communication wasn't out there. So reporting is going to be one of those keys. I've also found that if we have the data, if we use the data to make the case, we're going to have a lot better reception whenever I go talk to a group of physicians. That's just from my experience. If I can show, you know, even on an individual prescriber level, that this individual is far of an outlier from their peers, that's going to make a big impact for that individual. And so one of the technologies that we just recently have been kind of playing with as the Mercy system is really getting down to that level. So we actually have a system where we can not only just collect antimicrobial data, but we can actually look at an individual provider level and say, how does this individual provider compare to this individual provider? Or how does this unit compare to this unit? And so we're just kind of on the cusp of that, how we're going to use that data. But I think that's going to be very powerful in moving this forward for our institution. Reporting data to the C-suite, this is, you know, one of those things that we want to show. You're giving us the support, you're giving us the resources, here's what we're doing with it. So we have to be able to report that information. Post-unit specific data in visible places to engage the staff in stewardship, again, making this clear and making it available to all the end users. Distribute provider level information on antibiotic use. So again, comparing prescribers and giving them the information, showing them what that looks like in a graph to really garner that thought process. And implementing a real-time facility-specific dashboard for ASP metrics for all the staff to view. So this is something that, at least for Mercy, we're not there yet, but I think this is something that we can really shoot for. And I think that with some of the technology we have, we should be able to achieve that pretty soon. This is an example of something that we did. I partnered with our critical care pharmacists to look at this. And what we did was we looked at the empiric therapy combination for Pseudomonas. So we know that double gram-negative coverage is kind of a controversial topic. I think there's going to be more information about this. Obviously, the new hospital-acquired and ventilator-associated pneumonia guidelines were just released, and they address this to some extent. The HCAP guidelines HCAP was not addressed in those guidelines, but will be addressed in the new community-acquired pneumonia guidelines, from what I understand. And so I think that this is an opportunity, at least in our institution, we probably overused double gram-negative coverage, especially in the realm of pneumonia. And one of the things we were looking at specifically with this was our ICU. We basically started seeing a lot more meropenem use, and we see a lot of Levaquin being used as a second gram-negative agent. And so these are two things that I felt, just from an anecdotal perspective, from my daily reviews, was probably not the most appropriate thing for us to do. And so again, instead of just going around and telling people, stop using Levaquin so much, stop using meropenem, we actually collected the data, we looked at it, and we basically tried to figure out what that looked like. And I apologize, I realize that these numbers are kind of small, but basically what we found is that meropenem, at least in our patient population, really didn't add a lot from an empiric coverage standpoint for Pseudomonas. And so we can still consistently use piperacillin tazobactam. And so this is an example of something that we could do in our hospital. It may not apply to other hospitals, obviously, because the antibiogram is going to be different. We also found that really adding Levaquin doesn't offer much of anything from a gram-negative perspective, which seems obvious to me, but the data helps show that to the folks who are using the Levaquin. And so again, having that data is going to be really helpful. This is an example of some of the more granular information that we can get. And so what you see on the top is all indications for the use of meropenem. And then on the bottom, you have severe sepsis and septic shock. On your left side, you have days of therapy per 1,000 patient days. And on the bottom, you have months, basically. And so when we're looking at this, let's see, around here in March, this is whenever we did this combination antibiogram to look at this and gave this information to our providers. And so this is a way that we could trend data over time and look at what the impact is. And so this technology is also the same technology that we could use to look at individual provider levels. And I think that the key is to have that trended information. So not just that we're going to implement an intervention or an action, but we're actually going to track and see what the impact of that is. Another piece of feedback that we got from our providers is, if you're going to collect the antibiotic indication, you know, every time I order an antibiotic, what are you going to do with that? And so here we can show what we're doing with that, because we can look at the use of meropenem in each indication and see if that's appropriate. And taking that further, if it's not appropriate, then we can address the order sets and pathways that drug is represented on. And so meropenem is just one example, but you could apply this to any antibiotic. And so obviously the more data you have, the better you're going to be able to address these issues. And again, this is a very busy slide, but it's very helpful because what it's doing, at the top you can see just a sample of 4 hospitals in our system. And so we have the patient days, so you can get an idea of the different volumes of patients that we see. And then going across, you have days of therapy per 1,000 patient days. And so this is just an example. I just kind of extracted a few samples from a spreadsheet. And so down below, though, you can see the reason for the order. So then we further break it down into each indication and what we're using it for. A really good example of what we did with this data was down here, about 20% of our Zosyn use was for skin and soft tissue infections. And so I was questioning, is this really appropriate use? And this is actually representing a decrease. I should have tried to include the pre-data, but we were at like 25 or 26%. I felt like that was a lot for just skin and soft tissue infections. So we went back and we looked at what does that mean. And when we looked at our order set, it wasn't really clear when Zosyn should be used. We had complicated and uncomplicated cellulitis. That doesn't really make any sense. It doesn't help us choose antibiotics. And so essentially what we did is we put better wording on there. We said if you have an open wound and you have a risk for gram-negative infection like Pseudomonas or anaerobes, Zosyn may be an appropriate option. We actually put that in the order set to help guide providers because for a lot of people they said, our patients admitted they're very sick, they have cellulitis, that's complicated, so I'm going to use vancomycin. That's not what the intention was, but I think putting that information there, we saw that data, it showed that our use of Zosyn for skin and soft tissue infections, this represents St. Louis data at the bottom, it actually decreased really quickly. About 2 months, we saw that go from 25-26% down to 19-20%. And so again, it's just an example of how we can trend that over time and actually give that feedback to our providers. Surveillance of hacks and antimicrobial stewardship. Again, this is going to be a reporting piece that we're talking about, reporting our data to NHSN, and it just highlights the importance of working with our infection prevention counterparts to really understand, what their experience with it is, how do we succeed in that aspect. And I know personally that's what I'm going to be doing whenever we're having to report this data, is reaching out to our quality department and our infection prevention to help me with this. But it kind of underscores the importance of working with your infection prevention group. Further, with infection prevention, I think it's obvious, but I always try to make this connection because I could do the best I can with antimicrobial stewardship, but if we're not preventing the spread of organisms within our hospital, that stewardship effort is going to be a failure. So in our ICU, if we have a multi-drug resistant Pseudomonas and that spreads to everybody in the unit, then no matter what I do with stewardship, antibiogram is going to look bad because we have to overuse these broad spectrum antibiotics. And so I spend a lot of time, I meet bi-weekly with our infection preventionists, I work with the ID physician, and we all work very closely together and collaborate because most of what we're doing is crossing over. And so if you're not already, I encourage you to reach out to your infection preventionist, work closely with them. A lot of what we've had success from a stewardship standpoint on a system level has actually been driven by a C. diff work group that really was started with infection prevention. And so through that collaboration, we've made some really good inroads. We've developed a lot of good programs in EPIC, and essentially that was effective because of that partnership. These are just some of the other examples. Obviously, we know hand hygiene is really important, and some of the examples that we've done from an infection prevention standpoint to try to prevent infections in our patients. Microbiology, I think this goes without stating, but one of the things that we've benefited again is from having a very supportive microbiology department. They provide us with a lot of data that helps drive these choices. We obviously want to get the best technology that we can from a rapid diagnostic standpoint. The faster that we know what the organism is, the faster we know what the susceptibility is, the better we can do at de-escalating. And so one of the things that we did is we made a case from our antimicrobial stewardship committee to get a MALDI-TOF, so mass spec, to be identifying these organisms. We made a case for something called BioFire. Now it's owned by bioMérieux, but it's a PCR technology that rapidly identifies GI pathogens, blood culture pathogens, CSF pathogens. And so getting this technology in there has really helped us from a diagnostic standpoint, and then on the other side, obviously, from a de-escalation and patient care standpoint. This gives you an example, kind of another graphic representation of what Mercy looks like as a system. And you can see a lot of these little boxes, are places that are critical access hospitals. And what this is basically showing is that we have kind of regional hubs. And so we're trying to, this is representing a microbiology lab, but this applies to our pharmacy, to our physicians, and across the system. And so, anywhere where we can collaborate, we're trying to collaborate in those activities. And so I think that that's where we're at right now from a stewardship standpoint. Again, is how do we offer these stewardship services to places that are not geographically that close? And for me, as a co-chair of the system stewardship committee, trying to understand, what all these hospitals actually look like, because I work in the system, but I'm not very familiar with every individual institution. So it gives you an example of what we're dealing with. Clostridium difficile. This is, a big piece, and I think it's something else that we can focus on from a stewardship standpoint. From a reporting standpoint, we know that stewardship is one of the pillars of affecting our C. diff rates. And this is just an example from Dr. DeBerke at WashU. He found that the rates of readmission in the hospital within 180 days, 52% versus 23% patients with C. diff. This just shows the importance of what we're doing with infection prevention and stewardship in regard to C. diff. Attributable increased length of stay of 2.8 days. And something that I found interesting in this study was that there is a 62% greater odds of a patient being discharged to a long-term care facility or a skilled nursing facility, which is basically somewhere outside the hospital when compared to non-C. diff patients. So if patients came in and they got C. diff or they had C. diff, they are much more likely to go to a nursing home or an LTAC. And we know that if they go there, then there may be an increased risk of them acquiring other resistant organisms, and then those folks ultimately end up back in our hospital. I know for our hospital system, we have a LTAC that's not Mercy Hospital owned on our 7th floor. And so we rent that, the Mercy rents that space out, but that's a completely different organization in our hospital. And so I always think about that because it's the same hospital. We have the practices going on in our hospital, but those practices are not taking place there. And so then we share these patients back and forth. We get patients that are sent from Barnes and SLU and other large teaching hospitals in our area to that LTAC, and then those patients end up in our hospital. So just another thing to kind of keep in mind when we're looking at this. In this cohort, they had an attributable mortality of 5.7%. And they also looked at this in another study. They tried to put some data to this. I think the numbers now are probably closer to $10,000 to $12,000 per case of C. diff that's going to be added on. In this 2008 cohort, it was $2,500 to $5,000. I'm going to spend a little bit of time. This is the article that we just recently got published. It was a poster we presented a couple years ago, and it's a somewhat controversial topic, I think. But ultimately what we noticed was that for a long time, some of our physicians had anecdotally been using oral vancomycin twice daily as a preventative agent for high-risk patients at risk for recurrence of C. diff. And so when I first started, I thought this sounded kind of crazy and maybe not the best option. But having seen it in practice, and at least anecdotally speaking, I had never personally seen a patient break through this preventative dosing. And we don't do it for every patient. These are going to be people who have a history of C. diff, who come in the hospital and need to be on antimicrobials systemically. Oftentimes these people are at risk because of their age, because of their immune status, or because of the proximity to the last C. diff that they had. And we know that this is a consequence of C. diff. So what we did is we just retrospectively looked at 203 patients that we included. 71 of those patients received oral vancomycin and 132 patients did not. Of the people who received oral vancomycin, only 3 of those people had a positive PCR. And so that's not to say that they actually had C. diff infection. We couldn't really go back and say how many stools they had. I mean, we could look at white count, but we didn't really want to try to judge that retrospectively. We just reported positive PCRs because that seemed to be the most straightforward answer. But of that group, only 4.2% developed C. diff on that admission, and we looked for 2 weeks after they left. Obviously, that's a limitation in a retrospective study. We don't know exactly what happened to those folks after they left our institution, but for the best of our data collection, that's what we got. And then 35 patients, or 27% of the folks who did not receive oral vancomycin, same risk factors, did have a positive C. diff test. And so that was statistically significant. And it's really, to my knowledge, one of the bigger data sets out there on this concept. And so I think it's something that is, from a stewardship standpoint, from a, partnering with our infection preventionists, I think that this is an important thing to help validate a practice that was already taking place in our hospital. And obviously you want to do this with consideration, and it's not appropriate for everyone, but I at least wanted to highlight that as something that that was born out of our stewardship committee, was to look at that information. The education, I think this is obviously goes without stating, especially if you're at a teaching hospital. Education is going to be a huge component of your stewardship, opening up those lines of communication to all the providers. If you're not at a teaching institution, this is still important. Get in front of your physician groups. I mean, hospitalists are going to be prescribing a lot of antimicrobials. Critical care is going to be prescribing a lot of antimicrobials. And then the big thing that we need to work on is the community. How do we get better education, not just for our providers in the community, but for the patients in the community? Because we know that a lot of that's going to be driven by patients' desires. And so how do we get that education out there? These are all important pieces. This just gives a representation of some of the current activities we have. A lot of these things I've already mentioned. These are things that are going on locally in St. Louis. A lot of these things I've already talked about, so I won't go into a great detail. One of the things I will kind of bring out of this, though, is that we do have some antimicrobial restrictions. And so I think this is somewhat of a controversial issue as well. You know, a lot of physicians don't like to be restricted in what antimicrobials they can order. And so, you know, how do you do this thoughtfully without imposing on people? I know some people have kind of more of a approval process. So if you have a lot of resources with pharmacy, or you have ID fellows that can carry an approval phone, that may be a way to do antimicrobial restrictions. The way we do it at our hospital is a little bit more passive antimicrobial restrictions. So if the patient's in the ICU, we don't actually restrict the use of antimicrobials. We basically have a much more kind of open communication with our critical care physicians. We have a prospective audit, so myself and the critical care pharmacists are looking at these on a daily basis and give feedback to the providers. And I think that personally that has actually increased the amount of ID consults. So we took away the restriction, and all of a sudden then there was more increased ID consults for those critically ill patients. And so I thought that was kind of an interesting finding in doing that. On our floor-based patients, so the non-critically ill patients, we do say that certain antimicrobials are restricted for after 24 hours. So we don't want to prohibit the ordering of those antibiotics or the delivery of those antibiotics, but within 24 hours we would like either an infectious disease consult to kind of approve and or help support that patient in the providers, or they can de-escalate those antimicrobials if we find that they're not necessary. And so we found, at least in our institution, that that's successful. A lot of times that's hitting family medicine or hospitalist service, and they're very much on board with that process. So that's just one example of some of the things we're working on. From a Mercy system standpoint, we do have a monthly call with all the different hospitals that are able to participate in that. So we're trying to understand, you know, what's going on in all of our individual institutions. How can we help support those folks? We review order sets and pathways across the system, so this is kind of streamlining and using our resources to the best that we can. We have the system level interventions that I mentioned through EPIC, so the antibiotic timeout, the antibiotic indication, the notes that we have. So these are all helping affect all the hospitals in our system. Shared resources, but we obviously know that not one size is going to fit everyone. And so trying to tailor that to the individual needs. This has been a big thing that I've been working on as I took over the co-chair position of this, is trying to understand what the barriers are in each institution. And so maybe that is we don't have enough administrative support. And so from my standpoint, we might be able to send a letter from the stewardship committee for the system and help support that. Or our infectious disease specialty council can help support that. Or if that's something we don't have enough pharmacy resources, we can start looking at how do we utilize those resources better? Could we use telemedicine to help these folks? Formulary reviews and designations. Again, as new antimicrobials come through the pipe, we have to understand how do we best utilize those? How do we help set up the folks who don't have an ID physician, don't have an ID pharmacist? How do we help them? And so we put some criteria for use around the use of antimicrobials as much as we can to help those folks. Centralized data collection. This has been very helpful. So we have a centralized ability to look at days of therapy per 1,000 patient days, break that down by the indication, and then provide that data to all these institutions so that it's not on the individual pharmacist or the individual data collector at those hospitals. So that's taken a lot of that work off of those people and allows them to go out and interact and educate and intervene when necessary. And then, as I've mentioned throughout, establishing the programs to work with these underdeveloped programs. And so before I conclude, I'll leave you with these two quotes. And I think that this really highlights where we're at with antimicrobial stewardship and how we need to really look at this in terms of how we convey this message to providers and even to our patients. I think this is important. So antibiotics are unique because they are the only pharmaceutical agents that have transmissible loss of efficacy over time. And then antibiotics are a shared community property or trust, and clinicians, healthcare organization, patients, and the public are bound together in the need to protect these drugs from misuse. So I think that this is something that we can kind of take to heart and use this to help kind of set the stage when we're talking about stewardship. So in conclusion, If you're looking to start a stewardship program, now is a good time. We have a lot of momentum, so make the case. We have a lot of strong cases, especially in Missouri, that we highlighted. The National Quality Forum Stewardship Playbook that goes off of the CDC Core Elements is a great place to look for examples and options if you have barriers in your organization. Coordination with the folks in your hospital where these things are crossing over, like microbiology and infection prevention, are going to help garner support, especially if these programs are already more established in your organization. And then looking for examples of successful programs, both in literature and then regionally. I think this is something that we're using for our Mercy system, but it's something that I think regionally we could all share. A lot of everyone here represented probably has hospitals in your area that have stewardship programs. Get ideas from them, share ideas. I think that's going to help us all be more successful because we ultimately share a lot of the similar patients inevitably. So with that, I will potentially take some questions if we have time, and if not, thank you for your attention.